So today what we're going over is the posterior wall, and this first slide is just sort of an intro, sort of big picture intro to what we'll be looking at. So we've already talked about the celiac, the SMA, the IMA. We've already talked about all the organs that were in place as well. So once you strip all that away, that's kind of where we're at now. And remember, sort of file this away, we'll mention it again, but we talked about the kidneys being retroperitoneal. That's why you don't see them as soon as you open up the belly. So at this point, when you see the kidneys, that means you've exposed the peritoneum and removed it, or you've gone in from the flank. So of course, again, you see the kidneys, and you know these guys are responsible for getting rid of the liquid toxins that are in the blood. You're also introduced to the adrenal glands that are also called the suprarenal. The name suprarenal tells you everything that you need to know because it's above the kidney. Okay? So suprarenal, adrenal, it's the same thing. So whenever you think of adrenaline, you think of the suprarenal glands. Whenever you think of, there's a couple of different steroids that are also associated with the adrenals. So that's what you would be looking at. You also see the big blood supply, of course, coming from the aorta. We'll talk more about that in just a little bit. You see the ureters that are draining the kidneys all the way down towards the bladder, and then eventually out from the bladder throughout the external urethral orifice, which we'll see in just a little bit. So that's just the big picture overview. Now next, from this view, we just mentioned that these guys are retroperitoneal, so I think we actually showed you this same slide before, that you see the peritoneal lining. So that tells you that the intraperitoneal contents were here. We are behind that lining, so we are retroperitoneal. And it's a lot easier to cut a couple of these muscles, fascia, and sort of separate those to get to the kidney than it is to go all the way through the belly. But you'll also notice how the kidneys, and this is trying to show you this by showing you this fascia that's surrounding it. See where it's called the renal fascia? That's not the actual fascia that's associated with the kidney, but this is a fascia that surrounds the kidney and actually subdivides these two layers of fat, called a para and a perirenal, or a para and a perinephric fat. Because neph, in this case, is talking about the kidney, so you're saying the same thing. But this outer layer of fascia that you see here, this is the para, P-A-R-A. You have your renal fascia, and then within that fascia, that's where you see the perinephric or the perirenal fat and fascia. So it's really just providing like two buffers, two areas of protection for the kidney. And that's important to us because if you'll look, I believe on the next slide, you'll see that the kidneys are actually somewhat exposed. So if you go back to when we talked about the thorax, we talked about true ribs, false ribs, and free-floating ribs. Well, these guys are surrounded by the free floaters. Remember, those are ribs 11 and 12. So you'll see that they are free floaters, meaning they have no costal cartilage attached with them. It's just stretching out from the vertebral bodies and then they end. So you have those two layers of fat, the para and the perirenal. And then you've also got ribs 11 and 12 that are down here giving protection, but you'll still notice that these guys are exposed more on the inferior half. And you'll also see here the right kidney sits a little bit more inferior than the left kidney does. And that all goes back to the liver being so large and encroaching in that area that it pushes the right side contents downward just a little bit. Yes?
On the previous slide, what is the fat interior to the kidney? Like underneath the peritoneum?
Right here?
Yeah.
This is also part of the para.
Okay.
You'll see it here. It's also up here on the anterior side as well. That's why, I don't know if any of you guys have ever boxed before, if you've ever been in a fight and you've ever had a kidney punch. They hurt like crazy. You're sitting there smiling. What? Tell me, Conor McGregor, what happened?
That's my go-to.
Yeah, the old kidney punch? Yeah. The old kidney punch, I'm telling you. It is painful. I've never been in a fight and been kidney punched, but I've been kneed in the back playing basketball. I'm going to tell you what, painful, painful. You feel like you want to pass out. You feel like you want to pee. It's all because you got these different nerves back there that are responsible for different things, of course. So it sends these impulses upstream and downstream. Now, when you look at the kidney itself, we talk about some of the basic structures of the kidney. We've already mentioned that the para and the perirenal fascia surround the kidney, providing that buffer. But you have a renal fascia that's associated with this outer cortex as well, which helps to form this outer shell of the kidney. Yes?
So the perirenal fat is different from perinephric fat?
It's the same thing. Yeah, perinephric, perirenal, it's the same thing. Yeah. Neph in this case is related to the kidney. The same as like cystic was the bladder, the gallbladder. Cystic again today, or vesicle, is in reference to the urinary bladder. So from the outer shell, you have what are called renal columns, and you'll see that this is just part of the kidney tissue that extends medially down towards the center of the kidney. And what that does is it subdivides more of the working area of the kidney called these pyramids. The renal pyramid or medullary pyramid is talking about the pyramids that are located in the middle of the kidney. Okay, so the medullary pyramids, renal medulla, you're saying the same thing. They're just triangular in shape, so old anatomists call them pyramids because of what they look like, but they're just triangular areas. And what they're doing is they're taking that liquid toxin, filtering it back towards what eventually will become the ureter so you can pee it out. So you have the pyramids here, bottlenecking at a structure called the papilla, the renal papilla. So this is sort of the nipple on the bottom of each of these pyramids. And that sort of systematically allows the filtrate to pass through. It's not like a constant flow, but it allows just a little bit at a time to pass through. So you have your papilla, and then the contents of the pyramid and papilla dump into this first collecting area called a minor calyx. A minor calyx. You'll see here, that's the spelling, C-A-L-Y-X. Each pyramid and each papilla has one calyx associated with it, one minor calyx. Now, if we're talking about the funneling and the filtration here, so we're working from the outer portion of the kidney, working our way medially. So you'll notice that minor calyces then merge together, forming a major calyx. And usually you've got about 3-ish major calyces per kidney. So minor calyces drain into a major calyx. Major calyces then merge together, forming a larger collection area called the renal pelvis. Now the renal pelvis, this is still located within the kidney. I mean, everybody I'm pretty sure knows what the kidney looks like, at least the shape. If you've ever eaten kidney beans, they're named that for a reason, right? So this major calyx is still located within the surface of the kidney. And then as the major calyx starts to shorten and bottleneck, funnels together, that's what forms the ureter. The ureter then is what extends outward from the kidney down towards the bladder. So you have your pyramids to papilla, to minor calyx, to a major calyx, to the renal pelvis, down to the ureter. It's one big flow, one big filtration that's working all of this down into the ureter. It's a lot of terms, but it's pretty straightforward if you just kind of stack each step on top of each other. So far, so good? Now, the blood supply to this area, we're talking specifically about the kidney and the adrenals right now. They branch off of the aorta, or they are branches off of branches from the aorta. So I don't want you to get confused about the rule that we talked about last week when we talked about that big picture rule of threes. I kept saying there's 3 major branches off the anterior abdominal aorta, right? Anterior is the key, because there's still other branches that are coming in off of the lateral side as well, okay? So now we're looking a little bit more lateral when we talk about the kidneys and the adrenals. So you're right at the level of the cut celiac and the SMA, so you see those two here. So just off to the side of that, you should see one major artery coming off to the left, one major artery coming off to the right, and that supplies the kidneys on the respective side. Now, once you get closer to the surface of the kidney, the hilum, remember the hilum is just sort of the working area, the business area of an organ. That's where the structures are passing in and out, the blood supply, lymphatics, nerves, etc. So lots of organs will have a hilum. So as you approach this area, you'll notice that the artery starts to fan out into smaller branches. Those are lobar branches because there's different lobes of each kidney, usually about 3 to 4. So it's one big artery coming off the aorta that then splits or subdivides into 3 or 4 smaller branches. Okay? Same thing happens on the left side as well. Now for the adrenals glands are pretty unique because the diagram is making it look like these guys are just sandwiched right on top of each other, have a direct connection, almost as if there's supposed to be some magic little channel that's connecting the adrenal directly into the kidney, but in reality, they're completely separate, okay? They're just sitting there together. The adrenal sort of sits there like a hat on top of the kidney, but they're completely separate structures, right? What they do share is a little bit of blood supply. There's 3 main blood supplies to the adrenal, okay? So as big as the kidney is and as important as it is, it's got one big artery that comes to it. The adrenals have 3 different vessels coming from 3 different sources. There's a superior, there's a middle, and there's an inferior adrenal or suprarenal artery. The first one, you'll see here, are branches that come from this guy called the inferior phrenic. Now, we haven't really mentioned inferior phrenic at all until just now, but it's a vessel that comes off just lateral to the celiac trunk, and it helps to supply the parts of the diaphragm. Okay, that's where the term phrenic comes into play, right? Phrenic nerve heads to the diaphragm, C345 keeps the diaphragm alive, all that good stuff. So this blood supply is going up to the diaphragm to help supply it. The superior, you see here, the superior suprarenals, there's tiny little branches that come off of that inferior phrenic. So the first source for the adrenal gland is off of the inferior phrenic. The second source for the blood supply comes directly off of the aorta on the lateral side. You can see it here. And then the third source is off of the renal itself. That's where the inferior comes from. Now, we just briefly mentioned just a couple of things about the adrenal. There's a ton that's going on. You can spend an entire class just talking about the adrenal gland. So it tells you that there's a lot of blood supply here, especially with that superior, with all the little branches that it has coming off of the inferior phrenic. It tells you this guy's pretty important to us. Okay, so you've got a lot of anastomosis, you've got a lot of backup plans that are happening around this gland. So again, inferior phrenic, aorta, and renal. Those are the 3 main sources for the blood supply to the adrenal gland. Now upstairs, I can't remember on the cadavers how good this looks. I don't remember, to be honest with you. But I know that we need to see some of this if at all possible. Now I do know that one thing is standard, and usually I think we're able to save this on the dissection as well, is that for all of the arterial supply that we just talked about, there's one vein right here. One vein. It drains directly back into the left renal vein on the left side. The right side, you'll notice that it drains directly back into the IVC. Now, I may have mentioned this last week, I can't remember, I'll say it again, so forgive me if it's a repeat. But remember how the aorta is more left-sided, the IVC and the SVC are more right-sided, okay? So veins on the left side oftentimes will drain into a larger vein, and then those veins are carried across to the right side to merge with the vena cava. Whereas on the right side, the veins for these organs oftentimes will just drain directly back into the vena cava because it's a shorter distance to travel, okay? So that's what you're seeing here. Suprarenal vein on the left drains back into the left renal, carried across. Where you see on the right, it just drains directly back. Okay, so that's a real common setup that you'll see as we go through. Any questions there with the blood supply? Yes. I'm sorry? The vein that drains the adrenal? It's just the adrenal vein. Yeah, there's only one. Yep, so suprarenal, adrenal, just either right or left, depending on the side you're on. Now you'll also be introduced to something called the lumbosacral plexus here along the posterior wall. So of course, we have things below the, below the waist, so we have to have blood supply, we have to have lymphatics, we have to have innervations as well. So this is where you see some of these nerves passing downstream to either reach the pelvis, the posterior abdominal wall, or the lower limbs, okay? So for all of these nerves, we're not going to go over all of these nerves, okay? So don't freak out on me. But we are going to talk about a few of them today. We're also going to talk about these again once we talk about the lower extremity a little bit more in detail then, okay? Collectively, what you're looking at is called the lumbosacral plexus. And if you remember back, well, we haven't really talked, we talked about spinal cord, but we haven't talked about any of the limbs yet. But remember we talked about the cervical enlargement? The purpose of the cervical enlargement was what? Cervical enlargement for the spinal cord, do you guys remember? It's for the formation of the brachial plexus. Okay, it's for the formation of the upper limb nerves. There's also an enlargement in the lumbosacral region that helps supply the lower limbs as well. Okay, so what you see here is you're seeing these branches that are coming from that lumbosacral enlargement. So it's called the lumbosacral plexus. Now some of these guys are going to be just sitting along the posterior wall. So where we start for lumbosacral plexus is at L1. Okay, makes sense, right? Lumbosacral plexus. If you reach up and you feel T12, you should feel that 12th rib. Okay, so if you feel the free floater of the 12th rib, the nerve that runs just underneath that is T12. So that tells you the next nerve you see has to be L1. Okay, so you can use T12, you can use that 12th, the 12th rib as sort of a landmark to get you started. Just keep in mind T12 is not part of this plexus, right? By definition and by name, it's not part of it. So L1 is a lot easier to spell than iliohypogastric or ilioinguinal. Okay, so on the practical, if I happen to tag those, you can put L1 as long as it's still together. And what I mean by that is this. L1 comes off as one nerve, as L1. Okay? And normally L1 does not split until you hit the lateral body wall. And when it hits the lateral body wall, it splits into these two nerves, iliohypogastric and ilioinguinal. L1,
Which wall?
which
Some wall.
the posterior wall, and then it splits when it hits the lateral wall. So you have L1 that usually doesn't split until it hits the lateral body wall. This diagram is showing you that they are split all the way back, and they're doing that just to be complete, but it's not exactly accurate. These guys come off as one and they split downstream. So if we tag that by itself, it would just be L1. Okay? But you do need to know these terms for the iliohypogastric and ilioinguinal because you will see those again. The next one that's in line travels across, and you will see it actually enter in close to the area of the deep ring. I know we talked about the superficial inguinal ring and the deep ring a little bit. You'll see the next one close to the deep ring, and it's called the lateral cutaneous nerve of the thigh, or lateral femoral cutaneous. It's just a big cutaneous branch that comes off, passes through this area, does nothing inside the pelvis, and then it becomes sensory once you get to the outside of the thigh. But it's the next one in line, okay? So you have L1, and then you have lateral femoral cutaneous. And then you've got two nerves that are sort of sandwiched on top of each other. You can see the one here very clearly called genitofemoral. The name tells you that it's heading towards the genitals. There's also a femoral branch that continues down into the thigh. But it's sitting right on top of this muscle called the psoas major muscle. And we'll see that again in just a little bit, but file that away for now. So there's a genitofemoral that sits right on top of this long psoas major muscle. And then directly deep to the psoas major, we have another big nerve back here called the femoral. Now the femoral is a monster when it comes to the lower extremity. Okay, that's a big innervation for the quadriceps, the anterior compartment of the thigh. All right, so it is a big nerve. It's got a big job to do. And it sits directly deep, or directly behind that psoas major. And then the last one that we mentioned here is called the obturator. Now we will pick that up again later. but it's called the obturator. You see the spelling here. Obturator passes through the pelvis, goes through a small window called the obturator foramen. It's just an obturator hole. And that's how it makes its way down into the thigh as well, because it's also part of the innervation of the thigh. Okay? So it sounds like we got a lot of nerves back here. There's really just 4 or 5 that we're focusing on. We've got L1, usually together, but splitting at the lateral body wall. And when it splits, it's alphabetical. The H comes before I. So iliohypogastric is a little superior, ilioinguinal a little inferior. There's a lateral femoral cutaneous. There's genitofemoral and femoral sitting right on top of each other, or I should say right around the psoas major, let's say it that way. And then medially, you have the obturator nerve passing through the pelvis, not really doing anything, passing through an obturator foramen, which we will see on the osteology in a little bit, and then passing down into the thigh. Does somebody have their hand up back here? Yes. Psoas is P-S-O-A-S. Psoas major. Sounds like sore ass major. It's close to it, but not spelled the same. It's kind of funny if you understand what it does, which we'll talk about. But that is the beginnings of the lumbosacral plexus. Okay, there's going to be one other nerve that we will mention in just a little bit when we talk about the blood supply. Okay, I know that sounds funny, but there's a nerve we'll mention when we talk about the blood supply in just a little bit.
You said he's coming on
Lumbosacral plexus. That's just sort of the big collective name for this area. So now we're looking at the big picture blood supply back here as well. Now, remember we said before, rule of threes, we're talking 3 major branches off the anterior abdominal aorta. Here's your celiac trunk. Here's your SMA. And down here's your IMA. Foregut, midgut, hindgut blood supply. All that stuff should be a little bit familiar to you by now. We've just been introduced to the inferior pharynx. You see how it's supplying the diaphragm, but it also gives you which branches for the adrenal gland? The superior. The superior parts, the superior branches for the adrenal gland. Because you remember that the middle comes directly off the aorta, and the inferior to the adrenal comes off the renal, which is here. You see the left renal, right renal. So once you strip out all these organs and you're looking posterior, you see the aorta and you see the branches coming off. There's tons of branches. And as we've said before, there's branches that come off of branches downstream, but you're just looking at the main hub here and the branches coming off of the main hub. You're also introduced to the testicular or ovarian arteries. Collectively, you can just call them gonadal, okay? You'll see those again in a little bit. But the gonadals usually come off close to the SMA, but usually just a little bit below it, and they're on the lateral side. Now they are very small. Okay, they're very small arteries. They're protected very well. That's why they're so small. They can afford to be so small. But doing dissections, oftentimes they get torn. So I can't remember if we have good examples upstairs or not. So I want you to see what we're talking about here. Okay, these are the testiculars or the ovarians, the gonadal vessels. Usually just below the SMA, but on the lateral side. You see other smaller branches that are coming off to supply these intercostals as well. So I'm not going to go over all these branches, but big picture, these are some of the things that we've talked about. And then you see that the aorta comes down and it splits. Okay, the aorta splits at L4. That's a good thing to remember. That's another one of those good landmarks, right? L4. Splitting of the aorta. The aorta splits at L4 into 2 structures called the common iliacs. There's a right common iliac and a left common iliac. And remember, the name is common for a reason. That means it's going to split. Okay, just like the common hepatic gave off the gastroduodenal, it changed names to proper hepatic because it was destined for its organ, right? It was heading towards its destination. Here, this is called the common iliacs because it splits into an internal and an external iliac. internal and external iliac. Now the internals we'll talk about more on the next slide, so look at the externals for a second. You'll see that the externals continue passing through the pelvis on either side. They cross under Matthew McConaughey, and then they change names to femoral. So external iliac crosses the inguinal ligament and changes names to femoral. Femoral is a huge blood supply for the lower extremity. Okay, so this is kind of a big deal, how that vessel is progressing down into the lower limb. External iliac just becomes the femoral after it crosses the inguinal ligament. Internal iliac tells you, internal, it's staying inside the pelvis. Internal iliac stays in the pelvis. So this is sort of a zoomed in shot of just one half. This is the right side of the pelvis. So again, so there's no confusion, here's the common iliac. Common iliac splits into the external. Here's Matthew. This is crossing underneath it to become femoral out here. This is the internal iliac, right? Internal iliac. Now, this is where that relationship with arteries and nerves come together. So follow me here for a second. We said this is the internal iliac. Leave that alone for a minute. You'll see that you have the sacrum here, and you'll see that you have the sacral foramina. You have those openings of the sacrum that allow nerves to pass from the inside of the sacrum, pass out through those openings to the rest of the body, okay? This is still part of the lumbosacral plexus because it's inside the sacrum, okay? You're just looking at the lower part of the lumbosacral plexus. So specifically, I want you to look at something here. You've got a branch of nerve that's coming from here down into the pelvis, right? So lower abdominal cavity down into the pelvis. This is called the lumbosacral trunk. Lumbosacral trunk. It's L4, L5 merging together to meet up with these sacral nerves. So here you'll see L4, L5 branching. Here they've merged, spilling down into the pelvis. So if this is L5, this is L4, L5 together, which is referred to as the lumbosacral trunk. That tells you the next nerve you see has to be S1. Not only does it fall in line numerically, it's also passing through that first sacral opening. See right here? So if this is S1, then this has to be S2, then this has to be S3, and this has to be S4. Right? So we've got lumbosacral trunk, S1, S2, S3, S4. And you'll see that most of these nerves are all merging together to become a larger nerve downstream. Now how this works with the vessels, again, we're talking about the internal iliac, and we're talking about branchings coming off of the internal iliac and how they pass through the pelvis. So you'll see here that the internal iliac has a split to it. There's part of it here that's cut. We'll pick that up more on the next slide, okay? This is the part that stays more inside the pelvis, supplying some of the pelvic organs. This branch, this posterior piece, heads back towards this lumbosacral plexus, okay? So internal iliac has two parts to it, anterior, posterior. The posterior heads back towards lumbosacral plexus. Now, you will see 98% of the time that between lumbosacral trunk and S1, you'll see a vessel diving deep between those two. That's called the superior gluteal artery. Great relationship to remember. Superior gluteal artery dives deep through the pelvis between lumbosacral trunk and S1. Happens almost all the time. Now, in a med class of 20 to 30 bodies, you might see a variation up there where it doesn't quite, follow suit. But in general, vast majority of the time, superior gluteal artery dives deep between lumbosacral trunk and S1. Now hold that there 1 second. Look at the next slide. Now what you're seeing here is that, remember, the posterior part gave you that big branch, the superior gluteal artery, that continued here and dove deep through the pelvis between lumbosacral trunk and S1, right? Now what you're looking at is the anterior part. They've cut away the posterior, which means they've also cut away the superior gluteal artery. So here from this anterior part of the internal iliac, you'll see this is where you get most of your other branches. So let's follow the big part of this first. You'll see that here in this case, the inferior gluteal artery is diving between S2 and S3. You'll see right there it's diving deep between those two. Now I'll tell you, there's a 50-50 variation that happens here. Okay, remember we said like 98% of the time superior gluteal goes right in between lumbosacral trunk and S1. Well, I will tell you, from my experience, half the time the inferior gluteal goes between S1 and S2 as well. So inferior gluteal can go between S1 and S2, or it can go between S2 and S3. It's not a big deal, but when you're trying to understand these vessels coming off in the order that they're supposed to, you need to make sure you can identify them. I mean, you can see how this would definitely be a big deal for a surgeon trying to figure out which blood supply is coming from where and its destination, right? So inferior gluteal half the time goes between S1 and S2. The other half, it goes between S2 and S3. Which means the last big branch that is diving deep out of the pelvis, you'll see it here, is the internal pudendal. You'll see the name for it way down here because it's identifying its distal branching. But the origin of it is here. The inferior gluteal, there's internal pudendal. Now remember we said that there are branches that pass through the pelvis and there's branches that stay in the pelvis, right? So everything we've talked about so far are the branches that pass through the pelvis, heading back towards the gluteal region or heading down towards the groin area. Now the other branches that come off still are from this anterior part of the internal gluteal or the internal iliac. You've got an umbilical that you'll notice here is red and then here is yellow. What happens is that that's a remnant from fetal circulation. It's no longer needed. This used to wrap back up towards the liver. Okay? So this is no longer needed, so after birth it hardens and just becomes that fake ligament. It's called the obliterated umbilical at that point. But here you see the umbilical artery that drops off branches down towards the vesicle, which is a fancy way of saying bladder in this case. So you have vesicular branches that go to the bladder. Here you see more vesicular branches as well. Here's the artery that follows the obturator nerve through the obturator foramen, so that is the obturator artery. There's also branchings that come down here towards the rectum. Now, I don't want us to get lost in the pelvis, okay? The pelvis, I think, is the most difficult area for all the classes that we've ever taught. It just seems like the scores in the pelvis seem to go down because it's a tough area, okay? Tough dissection, a lot of work, not much reward to see. So it's a tough area. I just want to tell you this. Understand and learn the relationship with the superior, inferior gluteal arteries with the lumbosacral plexus. Understand that relationship. And then understand that if there is a blood supply that goes to the bladder, it's a vesicular. If there's blood supply that goes to the uterus, it's uterine. I don't care if it comes off your eyeball, okay? There's a lot of variation that can happen down here, especially with these downstream branches as they approach their organs. So name these guys where they go to. Name them by their destination. I don't care where they come from, okay? If it's on the uterus, it's uterine. If it's on the vagina, it's vaginal. If it's on the prostate, it's prostatic, right? Name it by its destination. There is a big picture set up on how this should work and how this should come off, but there's just a lot of variation, okay? So those branches with the lumbosacral trunk, that relationship is much more standard than some of these other relationships with the organs for the internal part. Make sense? I don't want you to get lost. So far, so good? Before we switch to the bony part, bony pelvis. Yes?
When it comes to the inferior gluteal artery,
Mm-hmm.
is that coming off the anterior trunk?
Usually. However, there's a variation where it comes off the posterior. The posterior can drop off the superior gluteal and then continue downstream and just become the inferior gluteal that dives deep between S1 and S2, or 2 and 3. So it's possible. So again, look for the lumbosacral trunk, look for those nerves coming out of the pelvis, and look to see what's diving where. Now, have you guys heard of the Body Farm that's out in Knoxville, Tennessee, associated with University of Tennessee? You heard of this before? It's a big forensic setup out there. What they do is they take bodies, they bury some of them, some they leave just exposed to the elements and the bugs, and they let Mother Nature do her thing, and they watch the bodies deteriorate out in the wild. And the reason they do that is to figure out, well, if somebody's been dead for 5 days, these types of bugs show up. This type of swelling occurs to the body. After 2 weeks, what's left? You know, there's different bugs that eat just cartilage. There's different bugs that eat just the fat, the skin, the muscle. So what they do is they try to determine how long has a body been exposed to the elements, how long has this person been dead. And the reason we mention that is that sometimes you just stumble upon bones in the woods, right? I don't know if we have any hunters in here or serial killers that don't want to admit it, but there's oftentimes just animal bones. If you walk through the woods, you'll see an animal bone lying there, right? So how do you tell the difference in an animal bone versus a human bone? Or more specifically for us, human bones, how do you tell the difference between male and female, right? So when you get to the pelvis, there's a couple of ways you can do that. Which one of these, just by looking at them, I don't think it says it anywhere, which one of these is a female, which one of these is a male pelvis? Female is where? A. Why is that? Yes. Okay. The flared ilia, that's wider. The circle here, the inlet, the pelvic inlet is wider. It doesn't do justice as far as the coccyx. It's making the coccyx look the same on both sides, but in reality, the female coccyx is pulled just a little bit further posterior. Otherwise, the birth canal, the baby would be twins when it comes out, right? If the coccyx is too far sticking out in space. So the coccyx is further back. You also see, notice the increased angles here. Decreased angle for the male between the symphysis pubis out towards some of these bony structures we'll see in a little bit. That's called the ischiotuberosity. That's what you guys are all using right now. That's what you're sitting on. So the increased angle is a female pelvis. The decreased angle is the male. Now something that's interesting to note here. These angles that you have for the pelvis are the exact same angles that you have for the thyroid cartilage. Okay? The male Adam's apple sticks out in space much further than the females do, right? It's because of the sharper angle. Females have a flatter thyroid cartilage that matches the same degree as the pelvis. Males have the same that matches the pelvis as well. Yes?
Yeah, so why?
Why?
I understand what pelvis, but why the difference?
Well, it also helps with phonation. It also helps with the tone. So that's why most guys have a deeper voice. Females have a little bit of a higher voice. So it's a big difference in the tone, the phonation.
What is the evolutionary basis for that?
What's the evolutionary basis? I don't know. I don't know. I can make something up, but I don't know. It was like that when I got here. I was born in '77. Come on, lady. What do you want from me? I'm not sure. Now, there are some bony landmarks we have to go over. You will see some of this stuff again once we hit the lower extremity. But you are looking at the inside of the right side of the pelvis, okay? The inside of the right side. So basically what we've done in this view is we've taken that view where we had the internal iliac cut and you were looking at the lumbosacral trunk, etc. We've stripped out all of that and now you're just looking at the bone. So on the anterior side, here's the as-is. Here's the pube tube. I feel like we've hit that to death now, but at least you're seeing these guys and how they sit anatomical position, okay? They're actually pretty much vertical. They're almost in a perfect line with each other. You'll also see here, this is the fossa for the ilium. So this is the iliac fossa, the iliac crest. Now the top of the iliac crest, if you connect both iliac crests on either side, that should be about the level of L4, which also just happens to be the bifurcation of the aorta, which also just happens to be the plane you want to go to if you're trying to do an LP, a lumbar puncture, because the solid spinal cord ends at L2, right? So hopefully we're kind of bringing some of this stuff back together for you a little bit. So iliac crest. You see here the articulating area for the sacrum. We're not going to talk much more about the sacrum today except for the sacral foramina that had the S2, 3, 4 fibers passing through. You see the rough area here. This is for the articulation for the symphysis pubis. Remember, that's that buffer between the two sides. We mentioned ischial tuberosity a second ago because, like I said, that's what you guys are sitting on, but that's also the further spread they are. That's how you see the female pelvis versus the male pelvis. Those two structures are pushed closer together. That's why you have the sharper angle between the two sides. You see here the ischial spine. Okay, so you have an ilium, you have an ischium, and a pubic bone for the pelvis. This is the ischial spine. Sticks out in space a little bit posteriorly. Just above the ischial tuberosity, you have the ischial spine. And you've also got this big opening here called the obturator foramen. Now, I mentioned it briefly when I talked about the obturator nerve that passes through there that heads down to the groin. I also mentioned it briefly when I talked about the artery, the obturator artery that follows the nerve. Now, the bony foramen is huge, but there's actually a membrane that covers 90-95% of it. So that means that the actual work passageway is very small. It's just big enough for a couple of vessels in the nerve. Okay, but the bony foramen is big. Now, if you flip this around and look at the outside of the pelvic bone, you'll see you still have the as-is and the pube tube. You still have the iliac crest. All of that is the same. But now you don't see the articulation for the pubic bone. You see much more of the tuber bone. Here's the obturator foramen covered by the membrane where you see more of just the canal that's left. And you see much more of the ischial tuberosity as well. Ischial spine still in place, and we will come back to these structures in just a little bit. I'm just showing it to you to be complete. And this is the acetabulum. This is for the head of the femur articulation for the lower extremity. We will talk much more about that here in about a month or so. But it's showing it to you now, okay? That's the acetabulum. Just for bonus points. Who knows what acetabulum means? It means vinegar cup. Makes sense, right? How many Olive Garden goers do we have? Olive Garden? One, half, don't be ashamed. I like it too. Soup, salad, breadsticks, unlimited, stupid deals. Next time you go to Olive Garden, ask them for an acetabulum, see if they know what you're talking about. It's what you're supposed to dip your bread into a little cup of oil, a little cup of vinegar, stuff like that. Old anatomists, you know, gotta love them. They're all crazy as hell. All right, moving on. Now we've got a dotted line here for a reason. Remember we said that the separation between the abdomen and the pelvis into the abdominal pelvic cavity was the arcuate line of the pelvis. Remember that? This is showing you that separation between the pelvis here, above the arcuate line being the false pelvis, and the true pelvis being the area that is below it. Okay, so the arcuate line again. You're also introduced to a couple of structures back here, these ligaments. Now remember before we said ischial tuberosity, and we said ischial spine. Okay, cool. Those are the bony landmarks. Without these ligaments in place, it was just sort of an open area, but once you attach these ligaments to the sacrum, which it didn't show you before, now you've got a much more stable area on the posterior part of the pelvis. Both of these start with sacro, so you know they're coming from the sacrum. The one that stretches from the sacrum to the ischial spine is a sacrospinous. Makes sense? And the bigger one that stretches from the sacrum to the ischial tuberosity is sacrotuberous. Sacrospinous, sacrotuberous ligaments. Once you have these guys in place, you now have two new openings, just like we had the obturator foramen before. Well, now we have a greater and a lesser sciatic foramen. Before, the ligaments weren't there, so you just had notches. You had a greater sciatic notch, a lesser sciatic notch. But now, since the ligaments are in place, you have a true circle, a true foramen. So it's now the greater and lesser sciatic foramen. It means nothing unless you plug in some nerves and arteries that are passing through this area. Okay, so we'll mention them briefly, but rest assured you will see this stuff again. Okay, so sacrotuberous, sacrospinous ligaments, once they are intact, that's how you then get the full formation of greater and lesser sciatic foramen. So far, so good? Okay. Now, in this area, what we're looking at, there's two triangles, male and female. And one of them is called urogenital. This would be the urogenital triangle, or UG triangle. Again, a little shorter to spell, UG triangle. And there's also the anal triangle. Anal triangle makes a little bit more sense because, of course, the anus is here. But urogenital is talking about the genitals and also the passageway for the urine, traveling downstream and eventually out the body. So this is the urogenital triangle. You'll see that the borders for it are the symphysis pubis, the coccyx, for both of these triangles now. We're talking about the whole area, this whole diamond area, the perineum. That's the name for this area, is the perineum. So symphysis pubis, tip of the coccyx, and then the ischial tuberosity on either side. So both ischial tuberosities, symphysis pubis, and tip of the coccyx. Now that is the diamond area for the perineum. When you subdivide that into the two triangles, you simply just draw this imaginary line between the two ischial tuberosities, and then you have your two triangles. Okay? So of course you're looking at things here. We mentioned that you have the anus for the anal triangle, but when you look more at the UG triangle for the female, you're seeing things like the glands for the clitoris. You're seeing the external urethral orifice. You're also seeing the vaginal orifice as well, along with things like the labia majora, labia minora, just your basic external structures for the UG triangle. Now for the male, again, the triangle borders are exactly the same. The UG triangle is a little bit larger, but the triangle borders are the same. Biggest difference here, of course, is that you have part of the penis and part of the scrotum that are passing through the UG triangle as well. You still see the glands for the penis, you see the body of it, you see a little bit of the scrotum with the raphe here in the middle. That's sort of like the collection area or the connecting area between the two sides of the scrotum. But again, the borders are exactly the same. So if we asked you borders for UG triangle, you could give us ischial tuberosity on either side and the symphysis pubis. If we asked you anal, again, it's the ischial tuberosity either side, tip of the coccyx. Or if we asked you all four borders for the perineum, you should be able to tell us that as well. Okay? Now, once we start to tear away the superficial area for the female, you're tearing away things like labia majora, labia minora, and now you're starting to expose some of the muscles that are associated with these triangles. Now, I'll tell you this. It doesn't mean that it's not important, but one of the hardest dissections to do with the littlest amount of reward is the anal triangle. Okay? We will talk about it. We're not going to spend a lot of time on it because there's really one artery, one nerve that pass through there. And it's tough to do. So much so that with the curriculum being changed for the medical class, we don't even do it anymore. Okay, because they're trying to get a little more focused on things that are, you hate to say more relevant, but more relevant. Okay, so that being said, understand what we're talking about. Super great for the written. Okay, there might be one question that pops up, maybe, but for the practical, not so much for anal triangle. Okay, not so much. That being said, for the UG triangle, there's much more to see. Again, your borders, ischial tuberosity either side, symphysis pubis. You're now introduced to a couple of the muscles. Okay? There's one muscle that comes up on either side. You'll see it here tucked underneath the pubic bone, here tucked underneath the pubic bone. That's called the ischiocavernosus. Ischiocavernosus. It's coming from the ischial tuberosity, stretching up towards the symphysis pubis. The ischiocavernosus. It's covering erectile tissues, okay? It is muscle, and it is muscle that is covering erectile tissue. It's called the ischiocavernosus. Now, if you look more in the middle of the triangle, you'll see there's another muscle called the bulbospongiosus. Bulbospongiosus. You see it here. You see it here. Now what this diagram is doing, it's also showing you structures that are deeper to the muscle. So it's also trying to show you a little bit of the erectile tissues, okay? We've got a slide that shows that stuff separately. Okay, so I don't want to focus on the erectile tissues just yet. But ischiocavernosus and bulbospongiosis are the two muscles that we see in relation to the UG triangle, the urogenital triangle. The first two muscles are covering the erectile tissues that help form clitoris or the penis. And the bulbospongiosis muscle, in this case, since we're talking about the female, contracts around the vaginal opening and helps to diminish the orifice. It helps to make it smaller. It also has a little bit of an impact on the external urethral orifice, which is here, but more so with the vaginal opening. And it's called the bulbospongiosis because there is something that is deep to here called the bulb. Okay, the bulb is more in reference to the erectile tissue, so the name doesn't make sense unless you talk a little bit about the erectile tissue. Okay? But for our purposes right now, ischiocavernosus, bulbospongiosis. Now these muscles are the same male-female. You'll see the male in just a little bit. There's also another muscle that you see here called the superficial transverse perineum. What in the world? Superficial transverse perineum. That is the muscle that helps to subdivide UG from anal triangle. Okay? I'm going to tell you what, superficial transverse perineum, it looks great in this diagram. That's as great as you're ever going to see it, because a lot of times it looks like fascia. Okay, it looks like fascia with a couple of brown muscle streaks running through it, and that's about it. So understand that that is your cutoff between these two triangles, and that's about it. Okay? It's not that it's not important, this is just a tough area. Yes?
I wonder, what does the sponges muscle does in male?
We'll talk about it. We'll get there. I like where your head's at, though. Any other questions here? Now, if you look, this is showing more of the muscle, not as much of the erectile tissue. This is where we mentioned a little bit of these nerves that pass into this area, and this is coming from the lumbosacral plexus. It's called the pudendal nerve. You'll see it here. The pudendal nerve. It's sort of the main hub that has branches that come off of it. So in this case, whenever you think of childbirth and you think of a numbing agent for this area, you want to feel right along the ischial tuberosity, go just below it, and you try to numb this pudendal nerve. Because you'll see that it stretches up towards the symphysis pubis, up towards the bulbospongiosis, down towards the anus as well. So you're trying to not only relax this muscle to allow for the vaginal orifice to expand, but you're also trying to numb the tissue of the area in case they have to do an episiotomy. You guys know what an episiotomy is? Yes, that's right. They do a systematic cut here down towards the rectum. So instead of allowing for the mom to tear, they make this systematic cut, which is much easier to repair later on, right? So if you just said, I don't know if you guys have had surgery before or torn a muscle, but if you just tear a muscle, surgeons have to go back in and just cut all the loose ends of the muscle and then try to piece it back together. But if you make a systematic cut through it, you can cut it in a way that's much easier for it to infuse properly, okay? So that's why this nerve is relevant to us. This is absolutely a clinical relevance here for the pudendal nerve. Keeping in mind, pudendal is a branch that comes from the lumbosacral trunk. And the pudendal nerve has a great relationship with the greater and lesser sciatic foramen. Those are the foramina that were formed only once the sacrotuberous and sacrospinous ligaments were in place. So I'm trying to bring all of that back home a little bit as well, okay? But pudendal nerve has a relationship specifically with the sacrospinous ligament, and that helps to subdivide the greater and lesser sciatic foramen, okay? This is where you pick it up, and that's the purpose of this. That's why we mention it more with female than we do with the male. Now for the erectile tissues. Remember earlier we said that the ischiocavernosus and the bulbospongiosis muscles, this was their positions, and they both covered erectile tissues. Well, in this case, the ischiocavernosus is covering what is called the corpus cavernosum erectile tissue. Ischiocavernosus is the muscle that covers the corpus cavernosum erectile tissue. And the bulbospongiosus muscle covers the corpus spongiosum erectile tissue. So basically what you're doing is you're just replacing the beginning of the name of the muscle and throwing in corpus. Corpus cavernosum, corpus spongiosum. Okay, ischiocavernosus is the muscle covering the corpus cavernosa erectile tissues. Bulbospongiosus is the muscle that's covering the corpus spongiosum erectile tissues. Now you don't have nearly as much of a bulbospongiosus, or excuse me, a corpus spongiosum aspect for the female. And the reason is that when you look for the formation for the clitoris, it's really just the corpus cavernosum erectile tissue on either side. So here you see the glands, here you see the body, and you really just see the corpus cavernosum on either side coming together, connecting, and then spilling anteriorly to form the clitoris, right? You don't see much underneath by way of the corpus spongiosum, because that's a little bit more of what you see here where it just says roots of external genitalia. This is what's nicknamed the bulb in this case for the bulbospongiosus. So you don't see this stretching upward nearly as much for the clitoris as you do for the penis. And that'll make sense in just a minute if it doesn't already, okay? But these muscles are covering erectile tissues. Like we just said, ischiocavernosus covers the corpus cavernosum, bulbospongiosus covers the corpus spongiosum, okay? Now when you look at it for the male, same thing's happening here. Remember, you have ischiocavernosus on either side. You have bulbospongiosus in the middle. But one thing you notice is different already is that the angles are different. The ischiocavernosus comes in sharper angle on either side. And the bulbospongiosus has no split in the middle. It's a solid muscle in this case. The reason it's solid, because remember we said for the female it contracts to help diminish the orifice of the vagina. For the male it contracts to help maintain an erection. It's helping to push blood down into the erectile tissues and helping to keep it there, because that's what an erection is. It's a erectile chamber that's full of blood, and then there's a small little sphincter that doesn't allow that blood to come out of those erectile chambers. It keeps them in those chambers. This muscle is helping to push the blood downstream and also trigger those sphincters to hold the blood in the tissues. Again, you see superficial transverse perineae. And I'll go ahead and introduce a couple of structures here that are both male and female, but this is a good example. So here's a structure called the perineal body. The perineal body. So if you think, we already said that the borders for both of the perineum, or both of the triangles here in the perineum, are the symphysis pubis, tip of the coccyx down here, and then both of these ischial tuberosities. Well, right in the middle of all this is a structure called the perineal body. Okay, I'm a baseball guy. I always think of the pitcher's mound because it's right in the middle of the infield, right? And then you got first, second, third, and home plate kind of surrounding it. So I always think of baseball. I'm a sports guy. But the perineal body is an anchoring mechanism, okay? And what it's anchoring here are the two superficial transverse perineae muscles on either side. Okay, so it's pulling those guys medially towards the perineal body. It's pulling a little bit of the external anal sphincter up towards the perineal body. And it's also anchoring the bulbospongiosus down towards the perineal body. Okay, so it really is this anchoring mechanism pulling all four sides together and also keeping everything sort of locally, sort of centralized, right in the middle of the perineum. Okay? That's the perineal body. It shows it pretty well there. That oftentimes shows up a little bit better than these superficial transverse perineae. You just kind of have to follow those fascias medially and then look between the anus and the bulb, and that's it. That's basically it. It doesn't stick out in space. It's just more or less like this hub, this connection area where you see these different structures attaching. So here you'll notice, again, ischiocavernosus, bulbospongiosus, but it's also covering the erectile tissues that are deep to it. The erectile tissues for the male, if you jump to the next slide, again, they're called corpus cavernosum, corpus spongiosum. So the name is the same, but the corpus spongiosum for the male is much more prominent. The reason is that the penis has three parts to it, but the clitoris only has two. Remember we said that for the clitoris, it's just the corpus cavernosum that come together and then wrap and spill forward anteriorly. For the male, you have all three parts. So here's the corpus on either side, the corpus cavernosa. Corpus spongiosum comes in underneath. The reason that you have the third part for the penis is because it's carrying the urethra. Whereas for the female, of course, you have the external urethral orifice just below the glands for the clitoris. But here for the male, you're using the same plumbing, the same ductwork, except this time it's carrying the urethra out towards the glands as well. So it's the corpus spongiosum that's carrying that out towards that external urethral orifice. So the glands looks the same for the clitoris and the penis. The body both look the same. Of course, one's just larger or smaller, but it's the same setup. So everybody always thinks about erection being only male, but clitoris has a small erection as well because it is erectile tissue that has blood trapped in it, that has a sphincter that helps to hold the blood in place. So it's just a smaller version of the penis, or vice versa, however you want to say it. That's why during development, have you guys had embryo before? You guys talked much about embryo? That's why early on we're basically identical, male, female. Then later on during development is when the actual differentiation takes place. So early on, it's really just the same thing. And then things happen. That's why you can't tell as soon as, for those who have kids, you know, the big thing is the gender reveal now, right? Where people go out and buy a cake and they tell the baker to put blue or pink icing on the inside, and then everybody eats it and they're like, oh, I'm so happy. And there's always somebody pissed in the background because they didn't want you to have the kid first. They wanted somebody else to have it. Anyway, gender reveal stuff, you guys ever heard of that? It wasn't real big with my first daughter. My second daughter, we did it because I'm a husband, and I just listen to my wife. So that'll take you far. That's a tangent. But yeah, that's why you can't tell until a certain about 16 weeks or so, because, you know, weeks, 1 through 15, basically everything's the same. You can't tell the difference yet. You guys haven't seen those gender reveal things? Like a buddy of mine had one with a golf ball that was filled with like pink smoke or something. He teed it up, he smacked it, pink dust flies everywhere, everybody claps, but then the wind was blowing, then everybody starts coughing because it blew right back in everybody's face. It was kind of fun. Now again, this is that same view that we were looking at a little bit ago for the same side of the pelvis, the right side of the pelvis. You're now introduced to the three parts of the male urethra. Okay, you can see the bladder, which we'll talk more about in a little bit. And then from the bladder, this is the first part of the male urethra. This is the prostate. So this is the prostatic urethra. Who knows what the function of the prostate is? I'm sorry?
Helps with generation of semen?
Not quite. Not quite. Prostate, appendix, nobody really knows. Nobody really knows. Yeah, we've got it. And it's more problematic the older you get because of hypertrophy, because it pushes in against the prostatic urethra, which means you can't pee. You got to go bad, 4 drops come out. You feel relieved until you have to go again in 7 minutes. Okay, this is kind of how it works. So prostatic urethra is the first part. There's a very small piece that I'm covering up the entire bit of it with the pointer here called the membranous urethra, and this is where it's sort of transitioning from the inside of the body to the outside. Okay, there's much more to that. There's some pouches here that we did not go into because it's a little confusing. You'll definitely hit it later, but this is the prostatic. The membranous is just here, and then the rest of the urethra is called the penile, or the spongy, because it travels in the corpus spongiosum. Okay, so prostatic, membranous, and penile. Penile is also called spongy. That's the 3 parts for the male urethra. Of course, the female urethra is much shorter. So that's why females have many more bladder infections, because it's a much shorter route back into the bladder, more so than it is for the guy. You're also introduced at this point to the testicle, which we'll see a little bit more on the next slide. But if you talk about sperm formation, this is where you're talking about it here in the testicle. And then it's stored in a structure called the epididymis. Again, we'll see that better on the next slide. And then once the sperm is pushed up towards the ductus deferens during ejaculation, it'll pass through the ductus deferens, wraps up through the superficial inguinal ring, deep ring here, circling back around. You'll see it working its way downstream towards the prostate, where then it meets up with a structure called the seminal vesicle. It's a little bit hidden by the bladder here, but it's sort of a nodular looking structure. It looks a lot like the pancreas. It has sort of that flaky texture to it. But do we have any Florida State fans here? Any Seminoles? Anyway, yeah, thank you. Seminal vesicle here. What's the purpose of the seminal vesicle? It secretes something that helps to neutralize the acidity of the vagina. Okay, so it does help lubricate the sperm a little bit, but it also helps to secrete enzymes that neutralize the acidity. Because millions of sperm are secreted, but normally only one makes it to the egg. The first one to make it to the egg is the one that's able to fertilize. There may be others that come in later, but the first one that gets there is the one that actually gets to fertilize. Most sperm is killed in the vagina or the oviducts that we'll see in just a little bit on the way up towards the egg. So seminal vesicle neutralizes the acidity of the vagina, mixes a little bit of seminal fluid with the mature sperm passing through the ductus deferens, and then it gets to pass through the prostatic urethra, the membranous urethra, and then the penile urethra as well. So like we say, it's a neat setup that you have both urine output and ejaculate going through the same passageway. Now specifically for the testicle, we talked about sperm formation. These guys are where it's actually formed, the seminiferous tubules. The seminiferous tubules, you see the spelling here, seminiferous tubules are these tiny coils that are bound together, and this is where sperm is formed. Okay? You'll see that there is a funneling towards here, a structure called the rete testis. The rete testis is a lot like the renal pelvis because you're draining all of the outside areas to a common collection area, right? So you got the same thing happening here. And then from the rete testis, the mature sperm is then stored in something called the epididymis. The head of the epididymis is here up top. You have a tail that stretches all the way down towards the inferior pole, which is close to the gubernaculum. You guys remember what the gubernaculum is? It's that anchoring mechanism on the bottom of the testicle that helped to pull it down into the scrotum during development. So at that point, you've got mature sperm in the epididymis just waiting for the ejaculation, and once that happens, it then gets pushed up towards the ductus deferens to work its way out. This is also a great example of the tunica vaginalis, parietal and visceral layer, just to kind of bring that back into your mind for a second. Remember that? The coat that surrounds the white coat is the tunica albuginea, and then this is the pocket that surrounds the outer shell, the parietal visceral layer, the tunica vaginalis. Now switch gears to the female for a second. Now for the uterus, of course, just like the stomach, there are different portions of the uterus. We mentioned fundus last time we talked about the stomach. There's also a fundus for the uterus as well. So remember, fundus just means it's a specific part of the organ. It's not a specific organ itself. Okay, it's just a part. It's a nickname for a part of it. In this case, it's talking about the piece of the uterus that sits superior to the oviducts, which you see out here. Uterine tube, oviduct, you're saying the same thing. Ovum is the fancy word for egg, so this is the oviduct, the passageway for the egg for implantation if it's fertilized. You see the opening here, this is the internal os. Os, os, just means opening. So there's an internal os as well as an external os for the uterus. So it's got basically two sphincters. So it almost acts as like two sphincters for the uterus. Sort of a backup plan there as well. Collectively, this area is called the cervix because this is where the uterus merges with the vagina and actually sits down into it a little bit. So you'll see the vaginal wall comes up on either side, and then it has to widen to accommodate the uterus sort of sitting down into it. Okay? So the cervix is the neck. Remember, cervical just means neck. So this is the neck of the uterus sitting down into the vagina. So a byproduct of this, the uterus sitting into the vagina, a byproduct of that is where you have the formation of what's called the fornix. Have you guys heard of the fornices before, the fornix? The fornix is not a physical structure. What the fornix is a space, right? This and this are the spaces that are created by the uterus sitting into the vagina. So those are fornices. Both of these are lateral fornices. But keep in mind that the vagina is that long cylindrical column. The uterus sits down into it. So the fornix just isn't on either side. The fornix goes all the way around that external opening, that external os. So that's how you get an anterior, a posterior fornix, and two lateral as well. Okay? So remember, fornix is more of a space than it is an actual structure. Now, of course, at this point, we talked about the oviduct just briefly. We see it again as it enlarges. There's an area here called the ampulla, and the ampulla is more important to us when we talk more about the actual egg, and if there's fertilization, implantation. You think of ectopic pregnancies a lot in reference to the ampulla. Here's the ovary, of course, secretes the egg. Now, here's the thing. Here's the catch. When you look at this diagram, it makes it look like the ovary is sandwiched into the end of the oviduct around this area here called the fimbriae. These little fingers, right? It makes it look like these fimbriated tips are just grabbing onto the ovary and holding it inside of that oviduct, okay? That's not actually happening. What's happening here is that the ovary does sit close to it, but there's no connection between the ovary and the fimbriated tips, and there's no connection between the ovary and the oviduct. So when the egg is secreted from the ovary, it is actually secreted out into the peritoneal cavity. And then the purpose of these fimbriated tips are to start to wave. Spirit fingers, right? And when they start to wave, for you cheerleaders out there, when they start to wave, they create a vacuum. And what it's doing is causing a vacuum on the inside of the peritoneal cavity to pull the egg that was secreted into the peritoneal cavity into the oviduct. It would make much more sense if it was just a direct connection, but it's not. Okay? It's separate from each other. The egg is secreted into the peritoneal cavity. The fimbriated ends start their waving, creates the vacuum to pull the egg into the oviduct. Then at that point, it travels through the ampulla. Sperm is traveling up this way as well. Fertilization can happen. Implantation sometimes happens in the ampulla. That would be an ectopic pregnancy. That's not good for survival. Sometimes it's possible that the egg that is fertilized can travel back out and then implant on the outside of the oviduct. That's not compatible with life either. Okay? So it has to be the perfect setup for this to happen. Childbirth really is a miracle, but so is the actual part of the pregnancy as well, the true fertilization. Because you think about how many sperm fail to do the job. It only takes one, but it's amazing how many times it fails. The reason I say that, it's like I go to church with a couple they're in their early 40s. They've been trying for 10 years to get pregnant. They've gone to the doctors. They have a lot of money. They've gone and tested all kinds of things. There's no reason that either one of them shouldn't be able to have a baby. It just hasn't happened. So when you think about that, it's like it's hard to understand, but it just happens, or doesn't happen. Okay, so it truly is a miracle that it happens. But of course, if it implants, like we said, on the outside, that's ectopic. Normally, you would like for that fertilized egg to travel back down to the uterus below the fundus, and then implant here along the inside of the wall. So that way you're away from the opening of the oviduct. You've got the two os. Remember we said it was like two sphincters. So that way it doesn't allow for it to pass downstream towards the vagina as well. It implants in the uterine wall, and then hopefully things go well. Not many slides left, 3 or 4, I think. So here you're looking at a sagittal cut through the body. You're looking at the female first. I don't want to belabor the point. You see symphysis pubis, you see bladder, you see the uterus with the vagina, and you see the rectum. Now, the reason we mention this is because we talk about, when we talked about the greater sac and the lesser sac, we talked about the fluids that wash downstream towards the pelvis. And if you wanted to sample those fluids, you had to get the patient to, if there was fluid in that lesser sac, you got to roll to your right, get it to drain out, and then ask the patient to sit up or stand up. So that way all of this fluid washes down towards the pelvis, right? Well, this is what we're looking at here. We're looking at these lowest spots of the pelvis where fluid can accumulate. So you'll see the bladder and the uterus. So the first pouch that you come to, this is just sort of the collection area between these two. This is called the vesico-uterine pouch. Remember, vesicle in this case means urinary bladder. Remember, vesicular arteries or bladder arteries, right? So you have a vesico-uterine pouch in between the bladder and the uterus. And there's also one between the uterus and the rectum called the recto-uterine. You'll see it here. And it's also called the pouch of Douglas. This is another one of those great examples of a guy finding something on the female anatomy and naming it after himself. Makes sense, right? But this is the pouch of Douglas, or the recto-uterine pouch. Now, I love to joke around, sometimes a little bit more inappropriately than I should, but there is a very serious situation that happens here at this recto-uterine pouch. More so in the past, not as much now, but it still happens. A normal position for the uterus should be anti-flexed. Okay, the fundus, part of the uterus, should be pushed and pointed forward towards the front of the body. Okay, so you have the angle of the vagina, and then it's almost a 90-degree difference for the inside surface of the uterus. So here, this is the inner lining. Vagina is here, so it should be close to a 90, maybe about an 80-degree difference from the vagina to the inside of the uterus. And where this comes into play is, I can't remember how many years ago, but there was a huge epidemic of abortions killing women. And the reason is that women were ashamed to have it done. They would go to people that weren't doctors. They would go to these back alley people to have it done, right? That way nobody would have to find out about it. So what they would do is they would literally use coat hangers, okay? They would stick a coat hanger through the vagina, thinking that they were poking the inside of the uterus, because they thought the uterus was just a straight shot from the vagina. Okay, so what you've done is you've taken contents from the outside world, you've introduced them to the vagina, which we've already said is acidic, right? Because the seminal vesicles help to reduce that acidity. So you've taken the contents of the outside world, you've taken contents on the wall of the vagina, and you've poked through that posterior fornix into this pouch of Douglas, and oftentimes they would poke into the large intestine as well. So now you've taken the contents of the large intestine, which we know is nothing more than poop and some water, and you've pulled that content now into the pouch of Douglas, which means that can spread throughout the body, which is sepsis, which we've talked about. And you've taken the contents from the vagina and the outside world, also introducing them into the pouch of Douglas and the large intestine. So tons of women died because of sepsis, bleeding and sepsis, because of this, because of not knowing the anatomy, right? Not knowing the anatomy, and the fact that they were doing this outside of a doctor's office, etc. So it's something that's very serious. It doesn't happen as often today, but it absolutely happens. Absolutely happens. I mean, people still show up at the emergency room here with botched abortions from boyfriends trying to do it, stuff like that. I used to take x-rays in the ED, and this was back in 2000, something like that. So in a year, I saw a couple patients come in that were doing that. I mean, that was 2000, so I mean, it was 17 years ago, but it still tells you this isn't something that was during the dark ages, which it was, but it still continues today. So it's a very serious situation, but it's simply not knowing the anatomy, knowing that the uterus should be more anti-flexed. They were poking through, doing tons of damage, instead of going where they thought they were going to.
What was that other pouch called?
Vesico-uterine and recto-uterine. Didn't mean to put a downer on that, but when you want to talk about very clinically relevant relationships, this is definitely one of them. Definitely one of them. Now for the male, of course, there is no uterus. So you don't have the two pouches because you don't have the extra organ that sits here in the middle. You just have the one pouch. So it's sandwiched in between the bladder and the rectum, or the bladder and the large intestine in this case. So it's just called the vesicorectal. Vesicorectal. Now, we talked earlier about the prostate, and we talked about the prostatic and membranous and penile urethra, etc. You see where the bladder and the prostate sit. They're directly attached to each other. You also see something called the ejaculatory duct. We didn't mention it earlier, but you see it now. What happens here with the ejaculatory duct is where the ductus deferens and the seminal vesicle meet. There is a duct that then passes through the prostate to merge with the prostatic urethra, because then at that point, like we said, you've got sperm coming from the ductus deferens, you've got the neutralizing agent coming from the seminal vesicle. It's all being mixed together in this ejaculatory duct to then be passed downstream. So this is a good view of that ejaculatory duct. It also tells you, I joked about it, but prostatic hypertrophy, prostate cancer. Prostate cancer is something that men die with and not from. Okay, most men develop prostate cancer. It just is what it is. Prostatic hypertrophy doesn't necessarily mean it's cancer, but prostatic hypertrophy and prostate cancer serve the same purpose in that it clamps off the prostatic urethra, which means urination is much more difficult, right? So you have to go in and you have to remove the prostate if it becomes severe enough, so that way you can alleviate that pressure, so that way you can go to the bathroom. But you see where this area is located at. It's sandwiched in between the bladder and here on the inside of the pouch that we didn't talk much about. But the best way to check for this is a digital exam. So you have to go in with your finger through the rectum, and then you can push right against the posterior lobe of the prostate. So when you push your finger in, you shouldn't feel the prostate yet. If you do feel prostate as soon as you put your finger in, that tells you that it is enlarged, okay? So if you don't feel it yet, you just push to the anterior a little bit more. And we always tell the students the way that we tell the difference for the prostate is a normal prostate. If you just take your hand and put it together, don't squeeze, you put it together, you kind of pinch right on that first dorsal interosseous. The feeling that you have there is fairly soft. And then make a fist, make it tight, and then push against it. You should feel the difference. So that's how you tell the difference on a digital exam if there's some type of hypertrophy, potentially cancer. So you're feeling for the softness versus that hardness. I know that sounds like duh, but it really is a good difference, or a good way to tell, because that does feel very similar to the prostate.
So you do this yourself?
Hmm?
You do this yourself?
I can.
This exam?
Hmm? Yep. Would you? Well.
That's my overall question. Like, instead of like, hey, you just do this yourself.
I mean, you could. Yeah, I mean, it's not as recommended as just like simply feeling your testicles for like extra nodules or an enlargement, things like that. Noticing differences of testicles is easy because, I mean, you can see, you know, for the most part, you can see. You should always have one testicle that hangs a little bit lower than the other one because of the venous drainage, okay, the way the venous drainage is set up. So, I mean, that's fairly normal. But prostatic hypertrophy, I mean, you can do the exam yourself, but usually you're going to see the effects of it first. Just not being able to go to the bathroom. You don't feel relieved when you go, or it's like, I just peed, I got to go back 45 minutes later, stuff like that, and you feel like you're about to burst again. Those are pretty common. So, I mean, if you know what you're doing, then maybe, but I've never actually heard of anybody giving themselves a self prostate check.
And why do they say go get a prostate if you can just look at the symptoms at the same time? I mean, the symptoms come at the same time.
They want you to also be seen because of testicular cancer, and they also want you to be seen because of rectal cancer, which is or colon cancer, which is a huge killer for men. So if you have something like prostate cancer, it's possible that it can spread for the colon as well. But they could also check it for polyps. They could also check it for downstream rectal lesions, things like that, maybe hemorrhoids. They could also kind of be a contributing factor to some of those. Any other questions there? Now for the bladder, if you cut open the bladder, you will see that for the most part, the bladder is made up of transitional epithelium, which means it allows it to expand and it allows it to contract. Okay, it makes sense because if it's full of urine, it's going to expand. If it's empty, it's going to contract. But this area called the trigone is a triangular area where it stays fairly smooth the entire time. So it has a physical difference look, it has a physically different look to it, but you'll notice that the 3 points of this trigone are the 2 openings for the ureters, either on the right or left side, and then the big opening for the urethra that's dumping the contents to the outside world. So all in between those 3 areas is called the trigone, and it should look different grossly than the rest of it. It's just more or less helping to funnel the filtrate downstream towards that opening. I know we talked about the heart with trabeculae carni and the papillary muscles and the pectinate muscles that massage the blood in the direction that it wants it to go. Here you need this to be a little bit more smooth, since this is more of a gravity aspect to it. It dumps in superior and empties inferior. So the look of the bladder here is more or less just for the expansion, not so much the massaging of the contents across. So that's why this is much more smooth here within that trigone. Now this is just showing you the difference between a female and male. I think you can get the idea again. I don't want to hammer home the point too much, but you can see the pouches here with the vesicouterine, rectouterine, no uterus on the opposite side. The one thing I want to mention here is something that I would be fired if I didn't mention. It's called the water under the bridge. Water under the bridge. What is meant by that? Water under the bridge, the water is talking about the ureter. So it's talking about urine passing through the ureter, okay? So that's the water. And the bridge in this case, especially for the female, because that's a more prominent relationship for the female, the bridge is the uterine artery. Remember, the uterine artery is one of those branches coming from the internal iliac going to the uterus. So the ureter should run just underneath the uterine artery. So that's the water under the bridge relationship. In OB clinics everywhere, that is a very important relationship to look for. You can, if you happen to cut the ureter, you can piece it back together, but it doesn't work very well. Okay, so if you cut a ureter accidentally, you can regain function, but only about half the function. Okay, and then if you have a backup of the ureter, now you have an issue with the kidney, so it kind of snowballs on itself. Okay, so this is something that's very important in clinics everywhere. Water under the bridge. You do have a water under the bridge relationship with a guy. It's a little bit more forced, and it's not quite as relevant to us. The ureter, again, is the water, but the bridge in this case is the ductus deferens, as it's traveling across. Like I say, it's a little bit more of a forced relationship. It's there, but it's much more prominent with the female, with the uterine artery being the bridge. And then the last slide that we'll talk about today is just the pelvic diaphragm. I know we mentioned before that the abdominopelvic cavity is bound superiorly by the respiratory diaphragm, inferiorly by this pelvic diaphragm. Well, there's muscles that form the pelvic diaphragm, and there's 3 of them, okay? There's 3 bones of the pelvis, and associated with each of those bones is one muscle. So the first one is coming from the pubic bone, so that is called the pubococcygeus, stretching from the pubic bone to the coccyx. Pubococcygeus. The next one that you see is called the iliococcygeus. You'll see it here. Iliococcygeus is stretching more from where the iliac would be. What's the specific structure? Brain fart. I can't remember the exact structure. You have a white line here that is fascia from another muscle. You'll see it here, the obturator internus. The obturator internus fascia is thick here. So even though obturator internus is not part of the pelvic diaphragm, it does have a thickened fascia that allows arcus tendinus. Thank you. Arcus tendinus. The arcus tendinus. That's another nickname for this white line. So the iliococcygeus has its connection from that white line. Arcus tendinus. So there's a pubococcygeus. There's an iliococcygeus. And the last one is called the ischio-coccygeus, since that's the third bone that we're talking about here. Sometimes it's just referred to as coccygeus. The reason I don't like that is because you put pubo and ilio in the first 2 names. So to be complete, I like to say the ischio, because to me it helps to subdivide it to make sure I don't get those confused. So there's pubococcygeus, iliococcygeus, and ischio-coccygeus, and you'll see that it stretches from here, you'll see the iliac spine close to it, stretching across. Pubo-ilio-ischio-coccygeus. Collectively, all three form the pelvic diaphragm. So whenever you think of like the Kegel muscles, the muscles if you're trying to strengthen the pelvic floor by tensing up the lower pelvic area, that's what you're working on, the pelvic diaphragm. Over here, you'll see it says levator ani, so don't get confused by this. Levator ani is just a collective name for these first two muscles, the pubo and the ilio. Once you add the ischio, that's when you get your full diaphragm, okay? And the last thing I want to say, so you guys don't get confused about this either, see the puborectalis? Puborectalis is just a small piece of the bigger pubococcygeus. Remember we said pubococcygeus goes from the pubic bone to the coccyx. Puborectalis goes from the pubic bone and only wraps around the rectum and then comes back to the pubic bone on the other side. So it is part of the pubococcygeus, but it's a piece of it that only wraps around the rectum and then comes back to the pubic bone. Okay? So those two are all one muscle. The puborectalis is just a small ring of muscle that's a subset of that pubococcygeus. You guys have any questions?
For the pubic diaphragm, you said it's the iliococcygeus, pubococcygeus, and the ischio.
Yep.
Okay, so does it include the puborectalis or no?
It does, but keep in mind, puborectalis is only really identified separately in cases of rectal prolapse, something like that. So if you're talking big picture diaphragm, pubococcygeus, ilio, and ischio. So you guys have lab Thursday. Let's make sure we're on the same page. We have lab Thursday and we have an exam Tuesday, right? Okay, and then you guys have spring break after that, right? And then when you come back, I mentioned it before, Dr. Peralt will give you your 2 head and neck lectures. Okay? He's somebody that you'll see again when you get to the med class. So it's not bad to be introduced to him now. I'll see you guys Thursday.